Sharon is a professor at Texas Children's Hospital and Baylor College of Medicine. She has worked on several collaborative clinical studies that investigated the development and implementation of clinical genomic tests, germline and tumor, for pediatric cancer projects. And of note, her work in germline cancer genomics was sparked by being awarded an Alex's Lemonade Stand Innovation Award. So thank you for joining us here today, Sharon. And with that, I will turn it over to you so you can share your screen and teach us about this topic.
Great. Well, good morning, everyone. As Jay said, I always try to say yes to Alex Lemonade Stand because it was actually a pretty critical point in my career. I had done a bunch of genetic studies. For those of you who have not been in the field this long, this is when this was all done by Sanger, and we really wanted to try to stop doing gene by gene. And the Innovation Award at the time was to do 50 genes at a time on 50 patients. So that sort of shows you how far we've gone. That was considered a high throughput study. So I know that Garrett Berdur talked earlier in the series, and he talked a lot about the individual cancer predisposition syndromes. So I'm actually not going to talk about the disorders very much. I'm going to talk about what we identify now that we're doing exome and genome studies in large cohorts of patients. So just my one disclosure, I'm a member of the Baylor Genetics Scientific Advisory Board. So if you think about the era of precision oncology, people often focus on defining and tailoring cancer prevention and treatment based on the characteristics of each patient. This, of course, is not a new concept. We've been doing this since there were drugs for the Philadelphia chromosome. But generally, when people talk about prevention, they're really talking about looking at germline analysis and how can we detect those individuals that are at increased risk of developing cancer. And what I really try to highlight is that really precision oncology requires clinical grade genomic testing and implementation science. So you can't wait and collect all your patients at the end of a study and then run them all in a research pipeline. And if you get data on 95% of the patients, you're happy. Really, precision oncology requires that you run them patient by patient as efficiently as you can, get a report on almost every patient enrolled, and return that back to the physician. So I want to just talk about how we got into this particular aspect of precision oncology. So back in 2011, NIH had what was called the Clinical Sequencing Exploratory Research Consortium. They had a request for grants that basically said, do you think you can do exome or genome scale testing in a clinical setting and return it to patients? So that was considered a pretty revolutionary idea in 2011. And so this is the group of institutions with some additional ones over time that were funded. And there were three group study sites that were actually selected for cancer germline testing. Our study here at Baylor College of Medicine and Texas Children's, the Michigan study that focused on patients in particular with sarcomas and other high-grade malignancies in both children and adults, and the Dana-Farber original study that focused on patients with metastatic colorectal cancer. This was our original team, and many of those individuals I still work with. Will Parsons has been my partner throughout. Amy McGuire and her team lead many of the psychosocial studies and behavioral science studies I'm not going to talk about. Richard Gibbs and Christine Eng were involved in the development of the clinical exome. And then Angshumoy Roy in particular over the years has played a critical role as our lead molecular pathologist. And so I'm going to briefly talk at first about the results of BASIC 3 because the study is completed. It was called Baylor College of Medicine Advancing Sequencing into Childhood Cancer Care. We proposed to enroll 280 newly diagnosed patients with CNS and non-CNS tumors, get a blood sample and a frozen tumor sample, do CLIA certified whole exome sequencing, and each patient had a germline and tumor exome report returned to the medical record. The results were returned with our genetic counseling team and the oncologist to the family, as well as the electronic health record, and then we followed them. So again, this was all CLIA certified testing throughout all the studies I'm going to talk about. And so the methodology was all published actually now several years ago when we were about halfway through the study, but I'm going to talk about the results from the completed trial. So one thing is just say it is important to really try to represent the population for which your clinic takes care of. And this paper was published, but these are the updated numbers, that in fact, the race and ethnicity of the basic 3 subjects was highly representative of the Houston population. And in fact, it turned out that about 46% of the patients in the study are Hispanic, and about 50% are non-Hispanic. And there's actually approximately 11% African American. So one of the things I will talk about today is this has given us the opportunity to compare the results of genomic sequencing when you look at a Hispanic versus non-Hispanic childhood cancer population. Of course, another aspect of diversity is that pediatric cancer has a very wide variety of cancer types, many of which are extremely rare. So one of the nice things about having an unselected patient population is we had both the expected tumors like neuroblastoma and Wilms tumor, but we also had some extremely rare tumors as well, hepatocellular carcinoma in children, where we were actually able to make some individually interesting observations as well as the overall yield. And overall, the study was about 2/3 non-CNS and 1/3 CNS tumors. So one point I want to make, which turns out to still be true pretty much in 2020, is that the people that report germline results and the people that report tumor results are often sort of different teams. And that was true in Basic 3, it's true in our Kids Can Seek study, it's actually still true in the MATCH trial. That for germline reporting, these are often people that are ABMGG, American Board of Medical Genetics and Genomics, or Association of Molecular Pathology, certified individuals, but who do a lot of germline reporting and also are comfortable reporting germline variation in genes that are associated with secondary findings. The tumor teams tend to be more based on molecular pathology trainees and pathologists working with oncologists. So throughout the study, and still true in our current study, if there's an unusual germline case, the germline lab tends to ping me and our genetic counselors. There's an unusual tumor case, the pathologists tend to ping our oncology colleagues to talk about it. So it's kind of interesting to me that these two kind of pipelines still exist for clinical reporting. So I won't go into the tumor reporting. I invite you to ask Angsham or Will to do that. I'm just going to talk about today really the germline reporting. Every patient in the study actually had all these different classes of data reported to them. Cancer, which I will talk about, medically actionable findings, a small number of pharmacogenomic genes, and recessive carrier status. But I'm just going to focus today on what did we find with regard to their cancer phenotype. Of note, if they did have another type of illness like a kidney disease, the exome lab would also report on those. So everyone had a germline exome and a tumor exome report in this study. So, of course, one thing that you can find when you report in the germline are variants of uncertain significance. These are predominantly missense mutations in protein regions with or without known function. Laboratories use a wide variety of approaches, including looking at conservation, computational prediction, segregation with cancer, to try and determine their significance. I should say that different laboratories may still report out the same variant as a VUS versus likely pathogenic or likely benign based on their own laboratories' data and criteria. And it does highlight that data sharing through ClinVar and other databases helps to decrease discordance. And I'll talk a little later about my work in ClinGen, which is really trying to minimize the number of variants of uncertain significance in cancer genes. But so what did we find? So these patients all had an exome, and the laboratory reported out any variant of uncertain significance in any cancer susceptibility gene. So one thing which we were frankly surprised to find is there was almost no difference at all between individuals self-described as Hispanic versus non-Hispanic on the number of VUSs. So on the left, you can see the median is exactly the same, but the distributions are almost identical. However, as been reported by others, African Americans do have an increased likelihood of VUSs being reported with really a median of 5 and a much wider range. And this relates both to the high level of diversity in the African population, as well as the fact that back in 2012, 2015, but even true now, we have less population data to compare these individuals with, control population. So what was the overall result? And I'm going to highlight this in some detail because, as I'll show you in a few slides, this is very consistent with what multiple other groups reported at the time and have subsequently reported, that almost exactly 10% of this unselected solid tumor pediatric cancer population, so 27 out of 278, had what we call a molecular diagnosis. So that means they had either a pathogenic variant in a dominant cancer susceptibility gene, or pathogenic or likely pathogenic in a dominant, or they had biallelic pathogenic, likely pathogenic variants in a recessive gene. And what you'll see here is only one of the 300 patients actually was diagnosed with a recessive condition. TJP2 causes a rare inborn error of liver development with liver scarring. And this patient had hepatocellular carcinoma. We actually identified 2 non-basic 3 patients with mutations in this gene and wrote this up separately. This particular inborn error of metabolism and liver disease is clearly associated with an increased risk of hepatocellular carcinoma. But there were no other recessive diagnoses. I don't have time to go into it in detail, but about 6% of patients have a single pathogenic variant in a recessive cancer susceptibility gene. And that's really important when you look at large series, because some people lump the single pathogenic variants in with the single dominant disorders and call them all a germline diagnosis. Whereas for many of these patients, we don't know if there is an increased cancer risk with having a single pathogenic variant. I will say the St. Jude study that I'm going to mention in a few minutes also found a similar proportion of patients with a single pathogenic variant. So in terms of what we thought was clinically significant, there were 26 patients who had a pathogenic, likely pathogenic variant in a dominant cancer susceptibility gene. And these 26 patients represent 19 different genes. So we did not find that P53 was the predominant gene, as has been reported in some other studies, I think mainly because this really was an unselected patient population. So we don't have an unusual number of adrenal cortical carcinoma patients or hypodiploid ALL patients, which has been seen in some other studies. In fact, P53 was found in 3 patients, and actually VHL was found in 3. The other surprise is it was split almost half and half. Patients who had mutations in genes known to be associated with that childhood cancer, so DICER1 in a child with pulmonary pleuroblastoma, and the other almost 40% had mutations in genes not previously associated with that cancer. And so this was one of the first reports, as was the St. Jude study, of BRCA1 and BRCA2 mutations in childhood cancer patients. That's now been reported by multiple other groups. And there is some more recent data that these mutations may, in fact, be overrepresented in childhood cancer. I'll give you an example from SMARCA4, which is a relatively newly described cancer susceptibility gene at the time, where I think it may be a new association that wasn't previously identified. And then again, as I mentioned, the recessive disorders are a rare cause of childhood cancer. As someone who spent much of my career studying these rare recessive disorders, that was disappointing, but it does seem to make up a very rare proportion of the overall pediatric cancer population. Just to highlight, because I'm not talking about the tumor data, and this is the figure from the original paper, is that of course there are a large number of patients who had somatic mutations in the tumor that are associated with changes potentially in targeting or treatment. They overlap with the patients with germline susceptibility. So you can certainly have a patient with a germline susceptibility mutation and then a second hit, or a patient who has a germline susceptibility mutation and then has a second actionable targeted mutation. It's not really an either or. So as I said, one reason we found some unexpected results is that we may simply not know about the association of a particular gene with pediatric cancer. So for example, we had one patient with SMARCA4 loss of function mutation in their germline who had a neuroblastoma, and our pathologist did go back and confirm that they felt comfortable with the neuroblastoma diagnosis. This is the next gene, the NGS sequencing of this patient, the germline on top, and you can see that about half of the reads have this 2 base pair deletion, which of course causes a frame shift. In this case, when you look at the tumor, what you see is that in the tumor, there's complete loss of heterozygosity. So every read in the tumor now has this frame shift mutation, which is fairly typical of what you would expect for a tumor suppressor gene. I should say that the group at St. Jude, who's done a prospective study, has also identified a child with neuroblastoma who has a different SMARCA4 loss of function mutation. And recently in Pediatric Match, where we're doing tumor and germline, there's yet a third. So I think this is an example of where it may be that loss of function mutations in SMARCA4 may cause a very small increased risk of neuroblastoma, as well as the more typically associated variants, typically associated tumors with SMARCA4, like rhabdoid tumors. So one of the things, once we completed the study, that we were interested in is whether we could predict who was likely to have a positive germline finding. So of course, age is what everyone's taught, and that's really based on adult cancer genetics, which is that in adults, early age of onset is much more likely to be associated with a germline finding. And what we show here is that, in fact, if you just look at children and we just split it into under 2, 2 to 12, and greater than 12, there really was no difference. The positive germline findings, and there was no statistical difference for the trend, the positive germline findings really didn't vary with age. The other thing is, I mentioned that this study was able to do, because we were split almost equally Hispanic and non-Hispanic, was again look what were individuals who were Hispanic more or less likely to have germline findings. And again, there was no difference. It was our power to do this for race was much smaller, but we also didn't see that. And interestingly, although I don't think I have it highlighted, there was really no overall difference between CNS and non-CNS tumors. So if you look at all comers, children with brain tumors were about 10%, as were the non-CNS tumors. So again, things that we typically think about as maybe being more predictive of germline susceptibility don't seem to play a role when you're looking overall. There clearly are individual tumor types like pheochromocytoma that do have a much higher yield. So one of the things I'm particularly interested in as a medical geneticist is how do we approach patients? So one of the things we did in the study is prospectively for each patient as they entered the study, we said, would we have done genetic testing for this patient? And if so, what gene? And then once we had the answers, we went back and looked at that. And really only of the 27 with a positive finding, only 11 of them did we predict that we would have done genetic testing for that patient. So there are a variety of reasons people were missed, some of which might seem obvious, like we don't recommend testing for genes like BRCA1 and 2. But it's also true that, we had a patient in the study with Noonan syndrome and had a PTPN11 mutation. If you actually look back on the record, the child does have classic features of Noonan syndrome, but it was not considered by the oncologist prior to getting the West results. And then I think what's most concerning is that patients with de novo or mosaic mutations, for example, may just never have testing based on current guidelines. So in fact, both patients in the study with WT1 mutations, neither of them would have had WT1 testing based on current guidelines. They were both unilateral, no family history, no congenital anomalies, which are the main indications for genetic testing. So that's just to kind of summarize that study. Now I want to kind of put it into the context of some more recent work, as well as other work at the time. I think all of you are probably aware of the large study published by St. Jude in 2015, where they, of course, looked at approximately 1,100 patients. They also found that about 8.5% had pathogenic dominant mutations across the whole cohort. They did have a very large cohort of hypodiploid ALL patients and adrenal cortical carcinoma patients that are known to have a very high likelihood of germline. It was still about 5.6%, even if you eliminated those high-risk cohorts. As I mentioned, they did, similar to our study, see a large number of patients with single recessive diagnoses, about 8.5%. So similar results in a larger study, but this was a retrospective study looking back on research exomes and genomes as opposed to our prospective study. This is a nice summary that Garrett first put together and I sort of added to. As I mentioned, the University of Michigan Caesar study published around the same time we did. Again, they looked at almost 100 patients. Again, about 10% were positive. Again, a variety of different genes. I mentioned the St. Jude study. This was our study. And then in 2018, a large European cohort, about 961 cases, collected over many years, again, found about 7 to 8% prevalence, and they did not know whether there was a family history. Again, variety of genes, including these adult onset genes like BRCA2, as well as the expected genes like TP53 and NF1. I should say it's not that different than adults. I participated in the TCGA pan-cancer germline analyses that got published, I guess, about a year and a half ago now. And that looked at adults with pathogenic germline variants in about 10,000 adults. And again, 8% were found to carry single pathogenic variants in mainly dominant cancer susceptibility genes, often with second hits or decreased expression. So what about if you think about individual tumor types? So as I mentioned, this large study out of Europe where they looked at about 1,000 pediatric cancer patients that was published in Nature a couple of years ago, they did try to break it down. And there clearly are specific tumor types that stand out that have even much higher likelihood of having cancer predisposition mutations. So you can see here that, again, adrenal cortical carcinoma and hypodiploid ALL are two of the largest. But remember, this is, again, a 25% line. So you can see how many different tumors are still in this 10%. It's really only very specific subtypes of tumors that fall much below 5%. So again, the idea that we had these very high yield tumors and very low yield tumors really doesn't seem to be playing a role. And again, they show you the different tumor types for the different genes. Once again, a wide variety of genes. I will say this LZTR1 is definitely a gene we've now seen reported multiple times now that it's been identified as one of the schwannomatosis genes. It also pops up on other patients. And again, this is a mixture of both adult and pediatric, with BRCA2 here being one of the more common ones. Then one of the beautiful things that's happened, of course, with sequencing of large groups of individuals is the identification that specific histopathologic subtypes can be an indicator of specific underlying cancer predisposition. So this, of course, is a paper, again, published in 2018, looking at both a retrospective and prospective cohort of patients with medulloblastoma. And I just really like the way they show this graphically. So again, overall, 11% of patients with medulloblastoma in the cohort carried pathogenic or likely pathogenic variants in one of the known cancer predisposition genes. These were the 6 most likely genes. And again, APC, patched, and SUFU were probably already known, as well as P53, BRCA2, and PALB2 was probably not as expected. And if you just look at these 6 genes, it's about 6% of the total prospective cohort had mutations in one of these 6 genes. But of course, the proportion that are positive vary enormously with the type of tumor. So this is about 6% in the retrospective cohort, but you can see that in sonic hedgehog subtype, it's about 20%, whereas in group 3 and group 4, it's only about 2%. And so TP53 variants are in fact extremely common in the sonic hedgehog tumors with chromothripsis. About 50% of them have a germline mutation in TP53. And then patch1 and SUFU are also present in the sonic hedgehog. Whereas the APC germline variants are in the Wnt medulloblastomas, and these are specifically those that lack somatic beta-catenin variants. So one thing I do always want to highlight is that there's sort of a yin-yang for many of these. There are a number of examples where if you have a somatic beta-catenin variant, you're extremely unlikely to have a germline APC variant. We actually use this now when deciding who to do testing on. That's true of medulloblastoma, it's true of hepatoblastoma and desmoid tumors as well. And so this is just a table from a review that Philip Lupin and I wrote last year, highlighting the number of examples now where if you are trying to minimize who gets germline testing, which I don't necessarily recommend, but if you are, that there are specific histologic or histopathologic subtypes that are associated with a very high likelihood of finding a specific gene. So low hypodiploid ALL and TP53, and then again, this ovarian small cell carcinoma hypocalcemic type with SMARCA4. So these are examples where looking at the pathology and the molecular classification of the tumor then gives you a much better idea of what's going on in the germline. So of course, all these studies were based on patients at diagnosis or during treatment. Last year, there was a major paper published looking at long-term survivors. This comes out of Xinghua Zhang and Les Robison and others at St. Jude's and many of their collaborators. So they looked at almost 3,000 survivors. So of course, survivors now have a different tumor spectrum than patients at diagnosis. And 439 of those patients had a second malignancy. Several of them had more than one. So there were actually 1,120 second tumors. So overall, 5.7% of survivors had a germline pathogenic or likely pathogenic variant, a cancer susceptibility gene. But this subgroup was definitely the group with an increased risk of developing breast cancer, melanoma, and sarcoma, as well as developing more than one second neoplasm. And there was also a genetic interaction between whether the patient was irradiated for the first malignancy and the tumor that they developed. So again, if you look at the survivors, the pattern is very similar to all these other studies, except for RB1 plays a bigger role here because they actually had a large number of retinoblastoma survivors in their long-term survivor study. But again, you see NF1, BRCA1, BRCA2, and P53. And these genes then did play a role in the likelihood of developing breast cancer as a second malignancy, even if those genes were not known to be associated with the risk of childhood cancer to begin with. I again think that that is a question that is really open for study. And I do think there's more and more data that at least for BRCA2, which is the most common of these genes, that there is an increased likelihood of finding a BRCA2 mutation in pediatric cancer patients compared to population controls. So to conclude this part of the talk, multiple studies now have demonstrated that about 10% or between 6 and 10% of diverse pediatric cancer populations carry pathogenic or likely pathogenic variants in predominantly a wide range of dominant cancer susceptibility genes. These are really a mixture of genes with and without prior association with the child's tumor diagnosis. Autosomal recessive diagnoses are actually a very small proportion of pediatric cancer patients. Our current clinical practice for genetic evaluation may miss greater than 50% of clinically relevant germline findings. And I think we definitely need consensus management guidelines for how to care for the increasing number of children diagnosed with hereditary cancer disorders. That's something that we've worked on with the AACR, as well as probably guidelines for who needs genetic testing. I wanted to spend a little bit of time talking about the fact that variant classification continues to change, and what the efforts of the ClinGen resource are doing. So just as an example from the BASIC-3 study, this was a child who had their initial exome report in 2012. The child had a pleomorphic xanthroastrocytoma and delayed speech, had a history of tumors in both the maternal and paternal lineage. So it's definitely a child you might consider having an underlying germline susceptibility. The original exome report revealed a pathogenic variant in DKC1, which is the gene associated with dyskeratosis congenita. And this was actually a promoter mutation in DKC1 shared by the mother. But remember, the mother had a family history of cancer. It actually had been described in an article in Human Genetics in 2001 in patients with DKC. And that study did functional analyses that showed it was disrupted an SP1 binding site. So the laboratory called it a pathogenic variant. I was actually fortunate that Alison Bertouche, who's kind of a world expert on DKC, is in my center. So I referred the patient to her. And she actually tested the patient for peripheral blood telomere length, which was completely normal. And really, that is sort of the diagnostic test for DKC. And the patient also did not have any evidence of bone marrow failure or other problems. If you now speed up time and you now look in the NOMAD population database of 100,000 individuals, there are actually 16 males with this variant, which you wouldn't really expect for a disease causing mutation that causes a very rare disorder. And it's actually very unlikely that using current classification schemes, which were not available in 2012, that this variant would have been called pathogenic today. So this is an example of a variant that went from pathogenic to probably more like a VUS. Conversely, we had a patient early in the study with adrenal cortical carcinoma and had a VUS in TP53, where we did extensive testing of the family and found that this variant segregates with cancer in this extended pedigree, which we didn't know about until we reported the variant. And other labs have now reported it, and it's now been reclassified to likely pathogenic. So I do think it's really important for people to pay attention, either in research or clinical studies, about how they're classifying variants, and also to be aware of some of the resources that are out there. So to just briefly talk about ClinGen, so I'm one of the principal investigators of the Clinical Genome Resource, which is known as ClinGen. It's an NIH-funded consortium, and our goal is really to build a genomic knowledge base and really to curate the clinical genome so that we can improve patient care through genomic medicine. And ClinGen actually looks at a variety of different questions, but I'm just going to focus on this main one, which is what's the evidence that a variant is actually causative for disease or pathogenic. We actually work on gene disease association and actionability, but I'm not going to talk about that today. So one thing to realize is just how we name variants is extremely confusing. And if you're going back in the literature, or if you're doing a genomic sequencing project, ClinGen does support the ClinGen allele registry. It has now over 1 billion variants in it, every variant in NOMAD, every variant in dbSNP, every variant in ClinVar, every variant in COSMIC, has a unique identifier and a website. And so for any given variant, and you can search by gene, cDNA, or protein, it then provides you links to where that variant is in ClinVar if it's there, is it in NOMAD, is it in dbSNP, et cetera, if it's in COSMIC. It also tells you every possible way that variant might have been named. And this is really helpful when you're looking at reports or different genome browsers that name variants different ways. So this is available just at the clinicalgenome.org, just under the registry. Civic now uses these identifiers, as does ClinVar and MLEVI. So it's just a way to keep your nomenclature straight, which can be harder than you think. Of course, what ClinGen recommends is that people submit their data to ClinVar. ClinVar aggregates variant information across laboratories. So this is just an example of a variant in CDH1. that has 3 stars because the star status tells you how good is the evidence that this variant, how good is the evidence that was provided on this variant. This was actually reviewed by the ClinGen CDH1 expert panel and was called likely pathogenic. But in fact, if you look in ClinVar, not just expert panels, but Invitae submitted to this, Ambry submitted to this, researchers submit as well, and it allows you to very rapidly see what have other groups called the same variant that you might be struggling with. I would say that the evidence status or the review status is very important because there is some very old data in ClinVar that has since been disputed or refuted. That data will generally not have a star, and the star status gives you an idea of how good is the evidence that's in there. So ClinGen now does variant classification. We develop expert panels, and we were recognized by the FDA as for our public human genetic variant databases. So all of the ClinGen classified variants get submitted to ClinVar with this FDA tag, and it also provides you links to all of the data on the evidence that we use to classify the variant. So this is just an example from last month. Since this process has been getting underway, I just highlighted in bold that we do have several expert panels that classify variants related to genes that are important for pediatric cancer. And each expert panel provides their variant classification guidance on our clingen.org website. So that you can actually, if you're studying a particular gene and you want to look at variants you've identified in a research cohort, and you want to know how did this expert panel say you should classify variants, that information is all available. And you can see that we always start out trying to classify variants from pathogenic to benign to demonstrate that our rules are working appropriately before we then do larger numbers. So then just to finish up, I just want to talk a little bit about what we're doing now. So after we finished Basic 3, we were pleased to be funded for a competitive renewal to launch a new study, which is called Texas Kids Can Seek Study, where we're again evaluating the utility and improving implementation of genomic sequencing for pediatric cancer patients, again in sort of the diverse population of Texas, but also now in diverse healthcare settings. I continue to work with Will Parsons, and Amy McGuire is the other PI of the study. And so our goal, sorry, this is lots of text, is to learn what genetic tests are most useful. So unlike Basic 3, where we only did exomes, now we're comparing targeted panels with exomes and other types of tests. And again, we're trying to understand how to be most efficient and how to disclose these results to the oncologist, patients, and families. And so this study is now open across 6 sites in Texas, actually 7 sites now. MD Anderson just opened. And we're enrolling children with newly diagnosed, or this time recurrent and relapsed tumors, lymphomas, and rare histiocytic disorders. We've got a diversity of clinical sites from private practice to academic centers, from smaller clinics to larger centers. Again, a very high level of diversity consistent with the state of Texas, with a focus on Hispanic individuals and Spanish-speaking individuals, and also a very large proportion of the patients come from medically underserved areas. So what's different this time is we're being more pragmatic. So the patients who have lower risk tumors, newly diagnosed Wilms tumor, are only getting germline analysis, where we're comparing a germline panel that was built for somatic cancer, but looking at it for the germline versus exomes. And then the patients who have high risk and relapse relapse tumors, this time we're using FFPE, not frozen. And we're doing an RNA DNA panel, and we're comparing that to to array, RNA-seq, and exome. So they get an integrated genomic report versus the RNA DNA panel. And every patient gets both, and we're looking at the comparative yield of those two. So this is just what's on the panel from the germline perspective versus what gets reported on the exome. So it's just underway, but one thing I would say that we did differently in this study is we actually tried to be much more efficient. So again, if you're doing a large study, the reporting is a huge amount of effort. So we try to report the panel and the exome together when they're both available. We send an email, and these are all kind of scripted text. We send an email to the oncologist when the germline results are available. We give them a summary of the results and our plan for disclosure and any medical recommendations based on the results. If they have a significant finding, a study genetic counselor returns the results to the family. The oncologist is invited but does not have to attend. And then it can be done by either telemedicine or in person. This turned out to be fortunate because of COVID-19, that we were already set up to do telemedicine, because now, because of COVID-19, we have switched completely to telemedicine for that. And for the non-significant findings, we actually send the family a letter, and that includes VUSs. We send the family a letter, a copy of the results, an educational brochure, and we make genetic counselors available to them if they have questions. This again turned out to be very fortunate because of COVID-19, because we're able to mail out the results even for our patients who are unable to get to the hospital right now because of the pandemic. So just to finish up, because I wanted to leave time for questions if there aren't any, a couple of cases. So these are from our Kids Can Seek cases. This was a 9-year-old patient enrolled with a diagnosis of glioblastoma. No significant family history of cancer, no additional clinical features. So this patient alone would not have had any germline testing. Because it is a high-risk tumor, they were enrolled on the Kids Can Seek germline and tumor arm. In fact, the exome found that the patient is heterozygous for a pathogenic variant in MLH1, and heterozygous for MLH1 gives you Lynch syndrome. And again, there was no evidence for a second hit, although the exome doesn't report deletions. The mother was heterozygous, again, with no significant family history of cancer that we were aware of at the time. The father didn't provide a sample. There were no other findings in terms of medically actionable. The patient was found to carry sickle cell trait, which I believe the family was already aware of. So just to remind people, Lynch syndrome is the heterozygous disorder due to a single pathogenic variant. Constitutional mismatch repair deficiency syndrome is the biallelic disorder, where you have a mutation in one of the mismatch repair genes from both parents. And brain and CNS gliomas are very common in CMMRD. They have been described in Lynch syndrome, but less frequently. And I would say in basic 3, we also had a patient just like this. It's frequently associated with skin findings and other findings similar to NF1. So the disclosure was in person. This is before COVID-19. The mom, the maternal great aunt, the parent were present, and the patient's nurse joined, but not the oncologist. So the family was previously aware of sickle cell trait. They did want to know if there was any relation to GBM. They were not aware of Lynch syndrome, and there was no family history. The mom did become quite emotional, particularly then hearing that she also carried this and has Lynch syndrome and needs screening. And that screening in adults has been shown to decrease mortality from cancer. The great aunt is sort of the primary information seeker, and she said they would definitely kind of have a family meeting, but she commented multiple times that I'm so glad we did this, or we would never have known about this. Unfortunately, we did see the family in cancer genetics. There were no other features of CMMRD on clinical exam. We did do comprehensive MLH1 analysis. All it found was one variant. There was no evidence for deletions or second variants. So again, this seems to be a glioma in a child with Lynch syndrome. The patient did pass away from the GBM. And we are going to see the siblings back. But this is an example where the result did not help the child, but was useful for the family. A second case to kind of highlight the tumor normal comparisons is this a 15-year-old, a right oral pharyngeal spindle cell rhabdomyosarcoma, no family history. And again, the tumor alone would not have warranted a referral to cancer genetics. You can see this large tumor here. So this was the tumor panel. And in fact, there were pathogenic variants in 2 different cancer susceptibility genes, in addition to the important MyoD1 change. So both a loss of function in Dicer1 and a loss of function in RB1. And so we were actually concerned that either one of these two could be germline, and neither of them really fit totally the clinical features. So I just want to point out that we published last month from the American College of Medical Genetics a paper about if you are doing tumor-only testing, exactly these kinds of results that might lead people to be concerned about germline variation, and how one might think about consenting for these tumor-only types of studies. But anyway, this was a tumor normal pair, and so in fact, the patient carried the Dicer1 pathogenic variant. They did not carry the RB1 pathogenic variant. And again, the mother was in fact negative for this. So we did learn that from the exome. The father, again, did not provide a sample, but this was clearly called pathogenic frame shift by both the panel and the exome lab. So Dicer1 syndrome, of course, is associated with rhabdomyosarcomas. These are often in unusual locations, like the bladder and biliary tract or uterine cervix. They're not necessarily been associated with RMS of the jaw, and a wide variety of other findings. So again, an example where the germline finding revealed something that otherwise would not have been identified by normal practice. So just to sort of finish up, the Kids Can Seek study we are over 60% patients from underrepresented populations, plus 70% if you include underserved. We've got really a diversity of clinicians and clinical specialization, and they have different access to genetic services. And again, we're comparing the panels with exome array and transcriptome to learn which are most useful. So just, this is actually the Kids Can Seek team. Luckily, before COVID-19, we had an in-person meeting, so people from across Texas were able to come, and we finally got a nice picture. These are the names. Sorry, it got kind of digitized there. And I just want to point out, although I won't show any data, the pediatric match trial is also ongoing. This study is doing paired germline and tumor testing. Every patient in the study gets both reports. Steve Jaffe at Penn and myself co-chair the germline reporting committee. And again, we work with 2 germline labs to write those reports, whereas they're molecular pathology labs that are writing the tumor reports. So to just say that, 10 years after the first tumor exome was reported, really we have the early realization of precision oncology for childhood cancer. We now have statewide and nationwide genomic marker indicated treatment trials for children with the worst prognosis. For pediatric match, over 900 patients from over 100 sites have been enrolled. And obviously, as new drugs come online, new treatment arms are being updated. But from my perspective, it's also the first national trial to do matched tumor blood analysis with germline status returned to the oncologists and parents. At least in the United States, there are studies like this underway in Europe and in Canada as well. And we hope that it does provide useful information for families, even if a treatment arm or treatment modality is not available. And with that, I'm happy to take questions.
Thank you so much, Sharon. Appreciate it. I want to start off with the first question.
Sure.
If other people have questions, you can put them over in the chat on the right-hand side of the screen. But early on in the lecture, you said that you had the AACR meeting and that you guys talked about how to follow kids. But then you said we need to come up with a consensus on what to do. What does that look like? What do we need to do to get to that point where we have a consensus?
Well, so I think in terms of following people, and I'm sorry I sort of took the slides out because I was determined to try to finish on time for once, because last time I gave this talk I went over. So I do think from the point of view of how, once you've identified a mutation in the child, how to follow them, I think there has been substantial progress made. So for example, after the AACR workshop, they did sponsor a website, which is actually still quite active, where we published like 21 papers covering something like 60 syndromes and what the recommendations for children with these disorders with regard to cancer surveillance. I am also happy to say that St. Baldrick's has now funded, it's just getting underway, a consortium to try to get even more data about which of the cancer surveillance guidelines are most useful. So many of you probably who are listening have seen the data out of Toronto, that the Toronto protocol for Li-Fraumeni syndrome, how that decreases deaths from cancer in children who are p53 positive. So I think their progress is being made, and I'm excited that the consortium may really help us get big enough numbers. I think where we need more of a consensus, and that's where like our current study is trying to report. I know that CHOP, I think, recently reported on their experience, and St. Jude's is doing a prospective trial, is really trying to argue, is there enough data? So is this 6 to 10% yield good enough to say that essentially every child diagnosed with cancer has a high enough a priori likelihood of a germline finding to have genetic testing? I think that, whether insurers will buy that or not, I don't know. But whether that's, in the end, it typically are groups like ASCO that make those sort of final determinations with regard to testing guidelines, or whether in this case it would be ASFO because it's pediatric oncology. You sort of need a professional group. The American College of Medical Genetics and Genomics sometimes makes these guidelines, although it's always a bit trickier for us because we also represent the testing labs. So it can sometimes be viewed as a little bit of a conflict of interest. But I do think there's more and more data being generated. I did take a slide out. There is a different approach that's been developed in Canada, which is called MyPod, where for each patient, when they're diagnosed, you go into this app and you put in all the information you know about the patient. It tells you whether this patient should have genetic testing. And we're trying to work with them on that. It's more on our end, trying to get the data transfer. I still think you're going to miss patients. You would still miss both of the Wilms tumor patients in our earlier study. I personally think the data is becoming convincing that all children with childhood cancer should have genetic testing. But I can tell you right now, that is not a recognized guideline, and most insurance companies will sort of turn you down flat if you can't document that their tumor type has a higher risk of having a positive finding. So I think that's where we really do need some professional guidelines that say this is a high enough risk and we know we miss important things by using guidelines. I mean, the last thing I'll say is I've been in this field a long time. A lot of these guidelines were developed when genetic testing was very expensive, when it cost, a couple $1,000s to do one gene. And so the guidelines were designed to be really specific, like, really testing people highly likely to be positive. But what that makes them is very insensitive. They miss lots of people who are positive that don't fall into those groups. And I think now, given the costs and the familiarity with genetic testing, we really need to move past that kind of guideline. So sorry, that was sort of a long answer.
And just a quick follow-up. So what is the average cost now?
Well, that sort of depends on who you talk to. And I'm not sure you need to do exomes. A lot of people would do large panels. So a lot of large panels cost $1,000. There's certainly companies that do them even cheaper than that. But it's in that range, so many of the companies that do large panels for adults, where they're doing hundreds of thousands of panels, charge between $500 and $1,000.
Okay. So the next question comes from Daniela, and she said, thank you for the very informative talk. Do you have any experience specifically with germline predisposition to myeloid malignancies?
So I don't. There is actually a ClinGen group jointly with ASH, the American Society of Hematology, that I shouldn't say I don't. I do, but it's not like my area. So there is a myeloid leukemia expert panel, and they've published their work on RUNX1, and they're now working on GATA2. And so these guidelines are now coming out on the clinical genome website. I would say the issues with leukemia are trickier because of often the need to do a skin biopsy or some kind of tissue sampling that is not blood. because often the variant could just be in the bone marrow, and what you're really trying to figure out is, was the child born with this variant? So it is a more difficult, and that's why I think it's a simpler ask for patients with solid tumors. But there is actually really a lot of work coming out of Lucy Godley and University of Chicago and multiple other groups around the world that are really focused on myeloid leukemia and the germline susceptibility to that.
All right, well, we're coming up on the hour here, and I don't see any other questions in the chat. So I think that that's going to bring us to a conclusion here, Sharon. This was very informative. I really appreciate you taking the time, and
no
appreciate everybody joining us today. And I'm sure I will talk to you again soon, but we appreciate you, Sharon.
Okay, well, great. Well, nice to see everybody.
Thank you.
All right, bye-bye.
Take care.